hi everyone. I'm Ben. I'm a second year PhD student at Queen Mary. My PhD is part of the Canditech program, and my team is focused on development of risk prediction models. And so we have a focus on early detection of UGI cancers in primary care. So just to give a quick bit of background, so I'm sure, unfortunately, most of you are aware that survival rates for UGI cancers are still really poor, especially for pancreatic cancer. And so this is mainly due to late stage diagnosis. And so, as I said, my team are focused on tackling this problem with risk prediction models. And so particularly for early detection. So to see how these models perform, but also importantly, how well we can sustain good performance further back you go before diagnosis. Next slide, please. So just before I started my PhD, my team did a systematic review of risk prediction models in the literature. So this included primary care, but also hospital-based models. And so of the, I believe it was 33 different externally validated models, machine learning approaches performed slightly better than conventional statistical approaches. But an important thing to point out is that a lot of these studies did not directly compare the performance of statistical approaches and machine learning. So I think one of the things that we're excited about is on our data to be able to directly compare the performance of these models on the same data sets. And then we also, as part of Canditech, have a health economics team to look at if these models are better, are they actually cost effective, and also a behavioral science team to actually help us determine all the challenges of getting these into practice and all the opinions of so clinicians and patients that would be impacted by this work. So also the review, would you be able to just go back a slide, please? Thanks. So with this review, they also identified over 200 different variables. And so this is the kind of long list of variables that we're currently working with as we go into building these models. And then in terms of what's currently available in practice to GPs, the main decision support tool is called Q-Cancer. And this is a multinomial regression model, which consists of symptom and comorbidity data. And so the main limitations of Q-Cancer is that it doesn't utilize any prescription or blood test data. And I think more importantly, in my opinion, it doesn't capture any of the temporality of the electronic health record. Next slide, please. So I thought I would just kind of develop that point a little bit. Apologies if it's a bit blurry, the figure on the right. So in terms of the temporality, like why I think that's so important, on the right is just a kind of mock-up of hypothetical lab test data. Firstly, I know that healthcare data is never as nice as this, and it's pretty messy. So this is obviously completely hypothetical. However, I just wanted to show the point that where these red crosses are, the example I wanted to show is that if you just have a simple regression model, you may have a situation where, in this example, patient A is determined as higher risk because they have a higher value for this, whatever blood test it may be, and all the actual context of that value for that patient is lost in a static model. So I think this is why we're very optimistic about these temporal models, and data such as blood tests and prescriptions and their changes over time. So on the left is just the data that we're working with. So we're working with CPRD Aurum, which is a primary care data set in England. I believe it actually has something like 40 million patients. We just have 17 million or just under 17, which is more than enough. And these are the different cancers that we're building risk prediction models for. Next slide, please. So before just going straight into building models, my first project of my PhD has basically been exploratory data analysis. And in particular, I've been building joint point regression models. And so what that is basically just trying to identify join points. Sometimes they're called change points, which is just where a change in gradient occurs. And so basically trying to identify for our variables which are most important for early detection, which variables can we see changes in our data as early as possible. And so what you're looking at are platelet count mean values for, on the left, our gastric cancer group, and on the right, our set of benign gastrointestinal controls. And so interestingly, both groups have a breakpoint at 8 months pre-diagnosis. But you can also see for our gastric cancer patients, the trend really increases around 27 months. And importantly as well, you can see that the actual mean blood test values are very different as well. So I've basically been doing this for, I think, 22 different blood tests and also for BMI, and doing that for our 4 cancer groups and 2 different control groups. So it's been quite a lot of analysis, and we'll hopefully be publishing this in the not too distant future, I hope. So yeah, if that interests you, you're welcome to stay in touch or keep an eye out for any announcements of this work. Next slide, please. So I'm aware this is seminar on machine learning, and unfortunately I haven't actually done any machine learning model as of yet. So this is kind of the work that I'm going on to do now. And so there's lots of kind of small questions that I'm thinking about at the moment in terms of study design and different approaches and populations. So lots of kind of small questions that actually have a really big impact on how this work may be implemented and how effective it may be. So just to give an overview, so as I said at the start, a lot of studies don't compare statistical and machine learning models. And so I'm interested in developing a number of different models. So logistic regression and comparing that to other single time point machine learning approaches. So maybe XGBoost or neural networks. And then in terms of temporal based models, you can kind of categorize that into 2 different types. So you have recurrent neural network based models, and then also your larger transformer based models. And then on the right is just a kind of flow diagram, an explanation of how this will actually work. So we'll be internally validating these models using CPRD Aurum. Then an important next step after that is for us to externally validate. And so we'll be doing that using CPRD Gold. And this is a similar data set to Aurum, just a slightly smaller one. And so this will be really important because often just relying on internal validation will give you quite an inflated idea of how well your models may perform in practice. And so the external validation will give us a much better idea of whether these models will actually be effective and give us better evidence to implement them. So yeah, as I said, there's lots of kind of small questions and details in terms of this next study and piece of work that I'll be doing. So if you have any ideas or questions, feel free to get in touch. Yeah, I think that's everything. Thank you.